Okay. Looks like we are ready to call our meeting to order. Mr. Priest, you on?
Yes, sir.
If you would, please call the meeting to order, and if you'll call roll, please.
Okay. Preble Acton. Here. Rhonda Allen. Here. Dr. Andrea Anthony. Here. Doug Bodery.
Here.
Amber Brown. Here. Shay Crowell.
I'm here.
Holly Deering.
Here.
Alan Farley. Mary Hickerson.
Here.
Lois Miller.
Here.
Lois is muted. Oh, Stacy? Stacy's muted.
Maybe trying to get her on.
Yeah. Hold up fingers. Tell me how many you got. How many was that? She went too fast.
She may be trying to get, she may have muted to try to get somebody on if they called her.
Well, I think we have a quorum. We got a quorum, Stacy? We have a quorum. Okay. Next on the agenda, members, is the approval of the minutes for the February meeting. Can anybody talk? Do we have any sound at all? Can anybody say anything? Nah, we've lost our audio. Hang on.
Yep, I hear somebody, static.
Stacy's breaking in and out. Hang on just a second.
Try to get everybody to get 2 sheets of paper. Yes? No?
Be like the Olympics.
Yeah.
9,
Yes?
8.5. Well, if y'all can hear me, we can't continue until we hear everybody. So I hope IT's working. Stacy, can you talk? I see your lips moving, but no sound.
Which,
Okay. She says they can hear me, but we can't hear them. Lee, in the control booth, Lee, can you, do you know that we're down?
yeah,
Working on it. They can hear you. We're trying to get the audio from them into the courtroom. We got a little issue right now, but they can hear you.
Okay, so just stand by.
Yeah, we're working on it.
Okay. All right, members, they're trying to tweak it, so everybody just take a moment, relax, and we'll get right back with you. Stacy, can you hear me?
Yes, I can.
Oh. That was the Land of the John booming voice. I think it broke the speaker.
My eardrums are still ringing. Hold on just a minute.
You're off. Okay. Do a test, Stacy, if we can.
Testing 1, 2, 3. Mic check 1.
Okay.
Better to start the roll call over again so we can.
Yeah. All right, members, I think we got it. If we could, let's go with roll call one more time.
Rebel Axon. Here. Wanda Allen.
Here.
Dr. Andrea Anthony. Here. Doug Bodery.
Here.
Shay Crowell.
Happy to be here.
Happy to have you.
Holly Deering. Here. Alan Farley. Mary Hickerson.
Here.
Lois Miller.
Here.
Alan McAdoo. Jeff Phillips.
I'm here.
Eric Tutobeni.
Present.
And Mayor Bill Ketchum.
Here.
Shante Sherrill had previously notified me that she would not be able to attend today.
Okay.
So we do have a quorum with 11 present and 3 absent.
11 present, 3 absent, so we do have a quorum.
Yes.
We'll move
Hey,
forward.
Stacy, it's Amber. You skipped over me, so I just
Amber.
want to make sure for the record.
Sorry. Yes, I had you on here. So sorry.
So it's
Alrighty.
14 or 12 present.
12 present counting you.
12 present, 3 absent.
Yes, sir.
Okay, we have a majority. We'll move forward into approval of our minutes from the February meeting. Do I hear a motion?
Mr. Chairman, this is Mary. I'll make a motion to approve.
Motion to approve the February meeting minutes. Is there a second?
This is Jeff Phillips, I second.
Second from Commissioner Phillips. Any discussion, corrections? Hearing or seeing none. We have to.
We need to call the roll for the
We have to
vote.
do roll call since we're doing this electronically, so if you would, Mr. Priest, please call the roll.
This is the vote to accept the minutes of the last meeting. Preble Acton.
She said yes.
He said yes.
Okay. Rhonda Allen.
Yes.
Andrea Anthony.
Yes.
Doug Bodery.
Yes.
Amber Brown.
Yes.
Shay Crowell.
Yes.
Holly Deering.
Yes.
Alan Farley. Mary Hickerson.
Yes.
Lois Miller.
Yes.
Jeff Phillips.
Yes.
Eric Tutobeni.
Yes.
And Mayor Ketchum.
Aye.
Okay.
Motion carries. Next, we have item number 4, financials. Mr. Elam, you're recognized.
Thank you. If you look at your Fund 264, you see the graph. For the current year, revenue at $25,493,138. Expenditures at $19,965,484. For the fiscal year, you see revenue at $57,365,117. And for expenditures, you see $59,249,085. If you flip over to the tracker, you will see for the month of March, we had $10,938,074 in revenue compared to expenditures at $6,628,774 and a difference of $4,309,301. What I will remind you in this, where you see the big gap between revenue and expenditures, the pharmacy rebate came in, and it was about $3.3 million, if I'm not mistaken, and that will be in this month. So that's where you see the big spread. One thing I want to point out, and I want to apologize, the numbers for 2019, the last tracker that you had, somehow the 2018 numbers were in it. It did have 2019, and it had all of the headings for 2019, but the numbers in that all the way across was 2018. It doesn't change our projections or anything for the rates, but it was an error, and I just wanted to point it out. If you look at the previous trackers, you'll see that the 2019 numbers are not the same numbers you see this month, but it has been corrected. For the 266, you will see that there's a OJI and workers' comp claims. There's a difference quite a bit from this time last year. And if you flip over to the tracker, you will see under the March column, $79,985.54 compared to this time last year at $49,729.33. But for the year to date, if you look to the far left in the box, for the year to date, you'll see the numbers at $402,437.57 compared to last year's year to date being $552,648.60. And we're running about, in claims, about 73% of what we were last year. That's my report.
Are there any questions for Mr. Edel?
Could I just add one more thing I forgot to mention?
Sure.
Based on the schools being out and a lot of employees being home, this workers' comp number is going to drop drastically probably in the next 2 months' reports. And we're going to put a footnote on the report. So when you see it, you'll see a footnote at the bottom that the schools were let out because of the coronavirus at their date, March, I think 15th, something like that. So you will see that just to give you for the next 2 years as we're doing a comparison why there was a drastic drop.
Other questions, comments?
Jeff Phillips, I move to approve the report, Mr. Chairman.
Have a motion.
Lois Miller, I'll second.
Have a motion from Mr. Phillips and Lois Miller on the second. Any further questions? Seeing or hearing none, Mr. Priest, please call the roll.
Rebel Axton,
Yes.
Wanda Allen,
Yes.
Andrea Anthony,
Yes.
Doug Bodery,
Yes.
Amber Brown,
Yes.
Shay Crowell,
Yes.
Holly Deering,
Yes.
Mary Hickerson,
Yes.
Lois Miller,
Yes.
Jeff Phillips,
Yes.
Eric Tutobeni,
Yes.
Mayor Ketron.
Aye.
We have the majority.
would assume that's 12 votes and
Yes, sir.
majority. All right. Motion passes. Next, members, we have the workers' comp OJI statistics from Mr. Good, our safety director. Dan, you're recognized.
Thank you, sir.
Go ahead.
On your report that hopefully will come up on your screen, or I can share it. As you look at the report, on the first page of the report, you'll notice for the month of March, we had a total 9 injuries that required medical attention. That brought the county total for the year to date up to 47. Of that 47, 32 of them are OSHA reportable, 20 have restricted days, 6 lost time days, and 6 all others. If you'll notice on the report, I put the note on here that the county schools are closed from March 15th through the end of the school year for the virus, and also that the county offices are closed from April 2nd to April 30th, what we're projected to at this time. As you look at the next page of your report, you'll notice that as far as this year is concerned, we've had 47 compared to last year of 51 and 2 years ago 67. That 47 reflects the fact that the school system was closed for 2 weeks of this year already. So that's why the numbers there are significantly lower. And for right now, for the month of April, we're quite a bit lower this year right now than we were last year. Last year at this time, you'll notice from the bar, we were at 36. And while this month is not over yet, we're only at 3 this month. That's work-related injuries. A little premature to project what this month will end up. Just kind of telling you how far it is down at this time. As far as the dollars incurred, we're at 127,000 right now for this year to date, compared to last year at 104 and the previous year of 223. Obviously, those dollars are even going to come down more in the month of April and May because of being out for the virus. Lastly, just to tell you where those injuries were for the month of March. 7 of those injuries were with the Board of Education. 2 of them were within the county, and the 2 in the county was with the county sheriff's office. That's all I have right now. Thank you.
That concludes your report, Mr. Good. Thank
It does.
All right. Is there a motion to accept the report as given?
This is Shay Crowell. I'll move to accept the report.
Holly Deering, a second.
Okay. We have a motion and a
Who was the second?
second was who? Who gave the second? Anybody want to?
Second was Holly Deering.
Okay. Holly gave the second. Okay.
Chairman,
Yes, ma'am.
this is Mary.
Hi, ma'am.
Hey, I got a quick question.
Yes, ma'am.
Do we anticipate if any of our first responders, emergency personnel folks get exposed to the corona and actually pick it up that way, would those actually be considered OJIs, or I'm hoping they get nothing, but or none of the virus, but could it potentially be that we take a hit on some OJI if that occurs?
That's been a long discussion. Right now, it depends upon the position they're in, the jobs they're doing, and the exposure, what it is. We've been taking reports. Well, we've had a few reports come in. Nobody has tested positive in the county first responders that we're aware of, or at least I'm aware of at this time.
Thank you very much, and I hope it keeps going that way, Dan. Appreciate it.
Thank you.
Mary, in my opinion, I think they would be covered. It's work-related. It's no different than work comp or OJI program, either one. My knowledge of the industry, you're going to be covered no matter what happens to you. Even
Yes, sir. That's what I was kind of thinking, but I was wondering if we, like I said, I hope we don't, but if we have some of these pop up Dan, could they potentially be put in another line item instead of just like under miscellaneous, so that with your notes of when school was out and the county offices was closed for it, we could always have that little line
You can identify it, right?
that identified that virus as, you know, just like we got fall slips and trips. Could we, if we ever had to add one, that way we could have it apart, like Ed said earlier, 2 years down the road, when we look back, we can see that this is why, you know, that's why that is, instead of just maybe falling under miscellaneous.
Absolutely. If I do have a report on that, I can put it in there.
Sonia, if you briefly want to explain, you know, what the federal government has passed, and so you understand, if they go under family medical leave under the COVID-19 legislation that's been passed, they get 100%, where if they go under OJI, they only get 3/4. And Sonia, you may want to touch on that for just a minute.
So for their first, they get 80 hours, I won't say 10 days, 80 hours for their first 2 weeks, depending on which option they choose. So if they have been tested positive, or they have been around someone and a medical physician has put them under quarantine, or, you know, there's several different scenarios. There's 6 different options. Those would be paid for the first 2 weeks at 100%. Then after that, they would go under, the only other option is the expanded FMLA, and that's for people who are out caring for a child because the child care facilities are closed. Obviously, if the child care facilities open back up, that wouldn't be an available option. But under that option, they're paid at 66 2/3, well, just 66, not 66 2/3, 66% of their pay for the next 10 weeks. The other options would no longer be paid. Only the ones, the first 2 weeks, those 80 hours that gets them out for the 2 weeks quarantine for their care. After that, they would go under an FMLA and be required to utilize their accrued leave time.
Okay, then that would lead to a question of how would, if there was any medical expense involved in that person getting tested or having to have medicine or treatment or anything, how would, it may be I think I see Paul Huffman on here, it may be a Cigna question because, you know, you go to the ER and it looks like you've had an accident, Cigna sends you a thing and says, was this auto-related, work-related, or just plain health? So could potentially, if we don't run it through a OJI, could we potentially have trouble with getting our employees covered if we're just trying to, and I understand wanting to get them all of their pay and everything, but I just also don't want them to catch a snag of something we're hoping it would get paid running through our regular health through Cigna, and it should have been run through OJI. And then, and if I'm getting way off in the deep end, y'all just say, Mary, we'll talk about this and I'll let you know what to do for your guys.
One of the things you might want to consider is it would be very hard to determine if someone tested positive for COVID-19 that it was as a result of their employment with the county, because they go to grocery stores, they go, you know, they're around other people. So to say that it was, that would be a very hard thing to isolate, to say that it specifically came from their, as a result of their employment. That's really not an HR, that's more of a OJI, but I think that if you were looking at it from an analysis standpoint, it would be really hard to determine that that was as a result of their work employment. Well,
Sonia, I'm not going to differ with that, but at the same time, in our meeting with all the mayors yesterday, Dana was there from the health department, and they are specifically tracking all those people who they come in contact with. So if it was one of our first responders working for EMS and they transported someone from their house to the hospital and they ended up being positive, then they start backtracking and who were you in contact with, et cetera. So I think that's what they're trying to do all over the state and all over the country is collect that data of who they have been in contact with. So I think there could be a point that they could potentially show that they did contract that and became positive because of that last person they transported. But this is all new territory for us. We've never been in a situation like this in our country. So, but I think we'd have a little bit more standing, I think, Mary, on proving that it was under OJI before we let it get into our hospitalization major medical program for benefits. Other questions? Concerns? Do we have a motion?
I think so.
Stacy, did we get a motion on that?
You had one from Shay and you had one from Holly. Did a second.
We did get a motion. We have
just
not
didn't do the roll
called
call.
the vote to accept yet.
I'm sorry.
Call roll.
If you would, please call the roll.
Preble Axton,
Yes.
Rhonda Allen,
Yes.
Andrea Anthony,
Yes.
Doug Bodery,
Yes.
Amber Brown,
Yes.
Shay Crowell,
Yes.
Holly Deering,
Yes.
Mary Hickerson,
Yes.
Lois Miller,
Yes.
Jeff Phillips,
Aye.
Eric Tutabeni,
Yes.
Mayor Petrin.
Aye.
Okay, 12 again.
12 votes in the affirmative. Thank you very
Yes,
much.
sir.
Motion passes. Now we'll move into the wellness update. Mr. Chapa, Cigna Wellness Coordinator. You're recognized, Chuck.
Everyone hear me okay?
I can.
Go with that?
Hit your mic, make sure. All right.
That'll work. All right, so the wellness numbers for March 2020. Annual physicals were at 682. Biometric screenings were at 1,126. Online health assessments were at 290. Mammograms were at 476. OBGYN screenings are at 716. Colon cancer screens are at 221. Cervical cancer screenings are at 605. Prostate exam screens are at 203. And flu shots currently are at 1,850. Currently sitting, we're at 1,118 individuals that have met their total incentive requirements for the 2020 year. Transitioning into kind of the new digital landscape that we're looking at. Traditionally, we do on-site visits during this time period. We're starting to ramp them up into May. We are working currently, Lee Smith and I, on converting those into digital meetings and capabilities. So as we put the finishing touches on those, we'll be doing digital meetings with different departments and the Board of Education throughout this time period until we can get back to a somewhat normal landscape of on-site capabilities. So again, those will be benefit education, Cigna products and services. We'll go over the new rates going into next year. Traditionally some of the information that we usually do, in addition to some of the new things that we have going on into this time period right now. We've started the conversation with St. Thomas going into things like using the mobile units and others. So we're going to identify kind of what that usage looks like as we get later into the year. And again, we figure out kind of what the on-site capability is using those things. And that will conclude my report for the wellness.
Thank you, Mr. Chapel. Any questions? Hearing none. Thank you so much. Next, we go to the wellness points discussion. Mr. Elam and Mr. Chapel.
Yes, I wanted to bring up a couple of things. earlier this month, I polled the committee talking about maybe let's suspending the wellness points, and I was going to bring it up to the budget committee, but due to the untimely death of Steve Irvin, I just thought it was best that we reassess that meeting and bring this back to the committee. So I wanted to open this up to the committee as far as looking at our wellness points. If you look at the report that Chuck gave, we're almost 5,500 people away from getting their full 3 points for their wellness points. And it's a concern of mine, and I've talked to St. Thomas, I've talked to Premise Health, a couple of things, and that is people trying to get in and trying to get an appointment since there's going to be such a backlog of appointments. And then also some apprehension in speaking to some of the population about even going back to the doctor now, even when they open back up, going back to the clinics and the doctor at the moment. I'm concerned that when we put this out there, that the people will be able to get to the clinics, get their points, and have it done by September 30th. Now, Chuck, correct me if I'm wrong, we're about it, normally every year about 89% to 90% of the members and spouses get the points they need for wellness. Is that correct?
That is correct. So we hover between like the 89 to 90 percentile.
So basically, and this is a discount that they get for the year. It's $300 reduction in their premium. So over the last several years, they've received this discount, so it's not like we're asking for a lot of new money to come out of the account. It would basically be, if we decided to suspend the points but yet give them the discount, it'd be about 11% of the members that didn't get it last year. You're basically, as far as the change in expenditures, it would be 11% that you would, that didn't contribute last year or didn't receive the discount last year, would get it this year. It's coming from the employees and their spouses, that totals up to approximately $200,000. So I'd like to get some feedback from the committee, see what you think. But again, I just have those concerns about people trying to get in a short period of time. And then if the virus kicks back in again, I think we're going to have some upset employees.
Any questions or discussion? Hearing none.
This is Mary.
Yeah, Mary.
So Ed, are you basically wanting us to give you a formal motion to take to budget to suspend these for this year? Is that what you're looking for today?
Yes, that's it. And I have something in writing here if the committee doesn't mind me presenting it.
Go ahead and read that, and if you want to, I have no problem based on the email swaps that we did in the discussion between everyone of making it a motion that we do postpone it based on several factors and wanting to keep the safety of our employees in check and just make it easier for even swapping over of the clinics too.
Okay, my recommendation is to temporarily defer the wellness points requirement to obtain the 2021 medical premium discount. The Rutherford County Commission will extend the monthly medical premium discounts to all county employees enrolled in the medical plan only for the year 2021. Wellness points qualification for the year 2022 will begin on October 1st, 2020 and end on September 30th, 2021.
I'll make that in a form of a formal motion for you.
I will second that motion. This is Shay Crowell.
Okay. on the second. We have a motion from Mary and Shay on the second. Any further discussion, comments? Hearing none, we have a motion before us. Mr. Priest, please call the roll.
Rebel Axton,
Yes.
Rhonda Allen,
Yes.
Andrea Anthony,
Yes.
Doug Bodery, Amber Brown,
Yes.
Shay Crowell,
Yes.
Holly Deering,
Yes.
Alan Farley, Mary Hickerson,
Yes.
Lois Miller,
Yes.
Alan McAdoo, Jeff Phillips,
Aye.
Eric Tutabeni,
Yes.
so we have 10 for yes, Mayor Ketcher, and 11 including you if you vote yes.
Okay, motion passes. Thank you, Chuck. Next, we have the Midpoint report. Shannon McNair. Shannon?
Thank you, Mayor. Can everyone hear me?
Yes.
Okay, I'm going to share my screen to show the report. If someone could let me know when they see that.
We got it?
All right. So we're going to go over our March report for the Midpoint clinics. This month at Midpoint for March 2020, we saw 793 total clinic visits. I do want to point out quickly that mid-March, we transitioned to a virtual first approach in our Midpoint centers for all 3 clinics. What that includes is that every appointment, we tried to see if we could take care of the members virtually to reduce their risk of exposure and transmission of the COVID-19 virus. So what we did is we scheduled them a virtual visit, and if it was essential that we needed them to come on site to get blood work drawn, a hands-on physical exam, something of that nature, then we would bring them in for a on-site visit. But we saw that a lot of members were very appreciative of this approach. Their fear of being exposed was very heightened at this point. So we saw a great transition to that, but we remained open and on site so that for those essential visits that needed to come into the clinic, we could bring them in, draw the blood, do certain point of care testing, et cetera. So if you see there on my screen, out of those 793 total clinic visits, 725 of those were provider visits. And I have a little side note there that shows that that's where our virtual, which are both telephonic and video, are reported in those provider visit counts for anything virtual that a provider saw. We had 49 medical assistant visits, 6 biometric only visits, 4 occupational health visits, and 9 wellness visits. Below there, you see our non-face-to-face encounters. We'll kind of see this further back in the report, but we have higher encounters there for non-face-to-face encounters for a total of 1,084. We had 283 orders only, and this could be medication refills if we decided they needed further imaging, something of that nature, but they didn't come on site to be seen, and we didn't do a virtual visit with them. That's what's captured there in the 283. We had 675 communication encounters, and that could be either telephonically, not a telephonic virtual visit, but just reaching out to the patient for communication purposes. And then we might also send them a message through the portal. And lastly, there you see 126, and that's where we reviewed results and sent out some form of letter communication to the member regarding those results. We do see a big increase in those non-face-to-face encounters when we transition to the virtual first approach. We started utilizing our team members to do some direct team member outreach, specifically those that are high risk related to COVID-19. So your diabetics, your hypertension patients, we did outreach to them to ensure that they were good on their medications, that they weren't coming up for a refill anytime soon, just ensuring that they were safe and ready to weather the storm, to say, throughout this COVID-19 pandemic. On the next slide here, we break down those provider visits. We had 488 office visits. We had 164 virtual, so that includes video and phone. We have seen a steady increase in our virtual visits week after week. I think more people in the community, the Rutherford County members, are getting more comfortable with those virtual visits. So we are seeing some of those increase this month in April. We did 34 annual physical exams, 5 sports or camp physicals, and 4 well woman physicals. I believe you guys have seen this in a report, but we haven't had the opportunity to discuss it. So this may be a new slide for some of you regarding our clinical quality measures for Premise Health. I just wanted to spend a quick minute talking about this slide. So if you see there in the top left box, it says goal equals 90% HEDIS. HEDIS is Healthcare Effectiveness Data and Information Set. It's one of healthcare's most widely used performance improvement tools. And it's a comprehensive set of standardized performance measures to provide reliable comparison of health performance. And so Premise Health's goal is to be in that 90th percentile of that information set when we're looking at certain clinical quality metrics. Right below the orange, you will see in the first column there that says diabetes testing. Right below that, to be at the 90% HEDIS benchmark, we would need to see greater than 93.67% of all of our diabetics be current with their testing. And I just want to point out that in this slide, we're talking about those patients that are attributed to the Midpoint Center as their primary care provider. So not total population, but those that have identified us as their primary care provider. So at the bottom there, you'll see with that for Q1 of 2020, we met that HEDIS benchmark at 95.45%. The next column is diabetes control. So some of you may be familiar with an A1C. That's kind of a 3-month look back at their blood glucose control. And the goal is to have it less than 8. And the HEDIS goal is to be greater than 64.96% controlled. And we hit that goal for Q1 at 67.44%. And then the last column there is hypertension controls. So the goal is you want to have a blood pressure of less than 140/90. And to be very specific, they could be 141/89. So the top number, the 141, did not meet goal, but the 89 did. And that would not be a goal met just because one of the two did not meet the goal. And if you look there at the bottom right corner, at 2020 Q1, we were at 79.63%, which meets the goal of 69.83. So I know that's a new slide. If you don't mind, I'll stop there and see if anyone has any questions.
Shannon, did you say that number was 141/90?
No, 140/90. So the goal is to be less than 140/90. So if the systolic, that top number is 140 or greater, you have not met that goal. And then same thing with the bottom number, the diastolic, that's 90 or greater, you did not meet the goal. 89 or lower, you did. And both numbers have to meet the goal to be in that control range.
This is Shay Crowell. I have a question.
Uh-huh.
I was just wondering, how big is the pool of people that this measures for the diabetes testing and for the hypertension control?
Yes. So running a PCP report, it changes very frequently because as we're doing this direct member outreach, we're updating our PCP members, making sure that we have it properly documented in the chart. And this is also a fairly new process for us. So I ran the numbers last week and we were at over 600, I believe, that were PCP attributed to the Midpoint centers, so 600 members. And again, that number, fluctuates based on conversations. If members come in and dedicate us and appoint us as their PCP, or if they decide to transfer their care out. Any other questions?
Any other questions for Ms. McNair?
I'll move on to the next slide then. Looking at the month-over-month trends. For March, this is just showing our month-over-month trends. These are the total clinic visits, and we do see that in March we had a decline to 793 total visits. And again, I made a little footnote there that this is when we transitioned to our virtual first approach mid-month. Essential visits only on site mid-March due to coronavirus pandemic. And then kind of the opposite of that on the next slide is the non-face-to-face encounters, and you see that it went up significantly in March. And again, related to the pandemic, we have increased our direct member outreach to our members to ensure that they're taken care of with medications, they don't need anything, they're not experiencing any symptoms. So we're checking on them pretty frequently. And then my last slide here is the summary slide. And so for March 2020, we had 596 total unique members. Our total operating cost was at $230,231. Employee count was at 6,252 for a per employee per month average of $37. And that concludes my report. If there are any questions.
Hey, Shannon, this is Amber. My question is, have you seen since the transition of going to virtual that people have to come back in for a face-to-face visit? Are you all tracking that?
We are tracking it. We do not see it a lot of times. When I talk about an essential visit, there's just certain things that our providers need to have a hands-on physical for, or blood work for. And so if we're in that situation, then yes, but our providers make every effort to give them the quality treatment that they need without bringing them in. But at the end of the day, we're there to provide quality care, and if it's required to give them the proper treatment, we will ask them to come in for a face-to-face visit.
Thank you.
Any other questions? Hearing none. Thank you, Ms. McNair, for your report.
Thank you, Mayor.
Item number 9, members, is the clinic transition update. Mr. Elam.
Yes, the only thing I wanted to mention was that the full, in the clinic transition update is that we met with St. Thomas this week. We have had the introductions to their team. St. Thomas has 14 team members on the transition. Risk management at this time has 4, and Cigna had 2 present in the meeting. And at the time we talked about each person's roles, implementation role. There's a task list that we have started. St. Thomas has got that we have reviewed, and part of those tasks have already been checked off. And they will be coming in in May with an update on where we are on the implementation part of it. And we've also, our OIT department has done a virtual tour of the clinics, and that has been completed and edited and in the process of being looked at by HR department and myself to make sure that there's nothing in the filming of it. There was nobody there, no computers were up, so we don't have to worry about computer screens or anything like that before that film is released. And if everything comes out okay, we will have that released to St. Thomas, and everything seems to be moving right along.
Okay, good. Let me, I just got a text from Doug Boder. He said, what happened to the meeting? It just crashed all of a sudden. So, Lee, if you're up in IT.
I'm back.
Is anybody on?
He says he's back.
You back?
Yes, sir.
Okay, so it was just one. Okay. Item number 10, 2021 health plan rates that the commission approved. Mr. Elam?
Yes, I just wanted to update the committee. The motion that left the committee was an option 2 vote with all the other items, the stop loss and everything. The budget committee and the full commission, with some changes to the HRA, the budget committee and the full commission went with the option 2 as was presented without any changes, and it left the HRA at the 95, 90, 90, 90, and that's what was adopted.
Okay, thank you. Item number 11, Embark benefit protection. Mr. Huffman, Cigna.
Thank you, Mayor Ketchum. Let me share my screen. And let's see. Let me know when you are able to see it.
We got it?
We got it.
I may not have the right one up, so let me make sure. Let's see. Here we go. You see the Embark protection there?
Yes, sir, we do.
Okay, let me put it on the screen. All right, thank you. Mr. Elam and Mercer suggested that I present this to you. I wanted to share some good news of a new benefit that Cigna and one of our affiliates, EviCore, is rolling out to our Cigna clients. And it is called Embark Protection Benefit. This is something that we're rolling out effective July 1st, 2020. As you may or may not know, there are currently 2 very unique gene therapy drugs that are on the market today. One of them is Luxturna, which treats a pediatric blindness. And the treatment for that individual costs about $850,000 for one treatment. Another one that you may have heard of is called Zolgensma. This treats spinal muscular atrophy for newborns, and it is literally a $2.1 million injection. And it literally saves the life of a child that is born with this condition. Right now, your plan currently covers all gene therapy. It covers these 2 drugs as they are today. If any of your members were to have these diseases, and these drugs would be covered, your plan would cover them just as any other illness. Your stop loss would kick in, and you would be responsible for approximately $750,000 if that occurred. And the members who receive this treatment would obviously pay their deductible coinsurance up to their out-of-pocket maximum. So what we're seeing in this industry is that about 10% of Americans have a rare condition that are related to a genetic defect. And we see that there are approximately 18 gene therapies that are seeking FDA approval in the next 2 to 3 years. So we know this field is growing, and the cost of these gene therapies are obviously very expensive. They're expected to be in the multi-million dollars over the next several years. By 2024, we anticipate that gene therapy will reach over $8.6 million. But again, that's spread across the entire nation. As I mentioned to you before, today, you do cover these drugs. They're covered under your plan. They're currently covered on the left side of this page. You'll see as in-network only coverage. They have to, receive this through an in-network provider that is delivered through our specialty pharmacy. We do provide a travel benefit for customers who are having to travel over 60 miles to obtain this prescription. The cost share is normal based on what their plan of benefits are, and they still receive dedicated gene therapy case management through our Accredo specialty pharmacy if that occurs. Going forward in July, when adopted, this program right now will cover these two drugs, Luxturna and Zolgensma. Because it's a network solution through our utilization management company, EviCore, the cost can be covered as under a pool. So we are literally charging every client who adopts this program $1 per member per month. That is going to cover the cost of the drug. It's going to cover all the patient's cost of the drug. So the cost share will no longer be required by the member. And again, this will also be through our Accredo specialty pharmacy company and through our network with EviCore. We will continue to have the dedicated gene therapy case management team deal with that individual, but it's going to be a pool. So we are going to spread the risk of all these claims across our entire book of business and even across all of competing business that EviCore sells this product to. The way it works, once it's in place, so July 1st, as a capitated per head cost, $1 will go through as a claim through your bank account. So pay just as any other provider would submit a claim to us, and we pay it on your behalf. This would come through that in that fashion. Physicians will determine if there's a need for one of these drugs, and they will request pre-certification from Cigna, from EviCore. And then once it's determined that that patient qualifies to receive it, then we will be in touch with the provider and the patient and get them to those dedicated resources. At that point, the customer will not have any cost to bear for the price of that. Not only that, your cost will be zero beyond that. So the cost of that medication is no longer charged to you at all. It kind of feels like stop loss. So you're putting a protection on a certain limit or a specific benefit. What it is really a network solution that we've created that we're going to roll out to all of our clients. Our company that we own, EviCore, will arrange for the provision of this drug on a prepaid basis because we're going to put that in as $1 per member per month. Again, members incur no charge for these drugs. And then the last piece that'll kind of rest your minds, right now for Rutherford County, based on 12,200 members, the $1 per member per month represents approximately $150,000 a year that would come through your bank account for this program. Well, the good news is we are going to evaluate all the claims that are paid out across our entire book of business. And at the end of the year, following the end of the year, we're going to do a settlement to determine what was actually spent and the cost for that. Any surplus left over is going to be returned to our clients pro rata based on what was paid in. This was a solution that we designed as a way to be to show predictability, because if any of these hit any of our clients, it could be devastating. So we're offering this across the board, and any surplus that is left over, we're going to be returning it, so it's not a money-making endeavor for us. We're somewhat agnostic as to whether or not that you choose to include this or not, although we would recommend that it is adopted by your account so that we do increase the size of the pool, and the more companies that adopt it, obviously, the better the risk. Anytime we prescribe any of these, or anytime either of these genetic therapies are delivered, we also follow up through efficacy to see the improvement, if it worked. So we're dealing with the manufacturers on the back end to make sure that it was administered appropriately and that it did work. If this program is in place, if these drugs occur, on your plan, you would not see them, nor would you not pay for them, but you would not see them in your claim experience. They would not impact your renewal, your cost, or your stop loss. The last thing I'll mention is, there's 2 on the market right now, 2 that we know of, several more coming. EviCore and Cigna are always going to be monitoring what is being approved through the FDA. And if it's determined that additional gene therapy medication needs to be added to this program, it will automatically be added. And if multiple drugs are added, and if we are seeing claims come through that are significant for this, we're also going to be periodically evaluating that $1 per member per month cost to make sure it is adequate. This is our first year. Like I said, we're starting this on July 1st, so we're kind of taking a guess at $1. And we'll know more at the end of the year if that's adequate or if it's way too much and we have to return it to you. But it's an ongoing process. And the last thing I'll say is for clients who have Cigna stop loss, which you do, we talked about a minute ago at the $750,000 pooling level, we are assuming that you're going to accept this program. So our stop loss contracts and our assumptions assume that this program is going to be isolated to this Embark program and not covered under your stop loss. You do, however, have the ability as a self-funded client with Cigna to tell us that you don't want the program. Okay, so you do have the ability to opt out of this and just cover it the way you're doing it today, with those programs just being covered as any other medical condition and subject to stop loss insurance. So I know it's a brief presentation. I kind of went through it fast. If you do nothing, if you tell us just to include it, we're going to assume that and we'll roll in automatically on June 1st. But if you want to opt out, then we'll put that in writing to me through a vote that you're doing perhaps today, and then I'll make sure that it's not included. But wanted to give you that information. If there's any questions, please feel free to ask.
Paul, this is Lois Miller. I have a couple of questions.
Yes.
So these claims would not roll through our stop loss, and so are we assuming then there's some form of stop loss credit? If
it's a good question. Yes. In most cases, 99% of the time, most of our clients have stop loss pooling levels at about 100,000, some of them 50,000, some of them 200,000. Rutherford County has one at 750,000, so it's quite high. I would say the impact of the credit is negligible in your stop loss, and so what I'm going to say is if you opt out of this, I do not think there is going to be impact to your stop loss rate that you've already approved for July 1st.
And on the opposite side, we wouldn't get a credit going forward because we just renewed the stop loss at a certain rate, and this wasn't mentioned. So just wondered if there was a little bit of credit. Okay, and then my other question is, I understand that the claim literally would not exist in our paperwork. It would be taken out of our claims reporting and so forth and so on. Is there any kind of a notification to people who have a need to know, like Director Elam, if this program is actually used so that we can understand the efficacy then to our claims?
Yes, we would. We would report on that if you did have an occurrence, so that everyone is aware.
Okay, thank you.
Mr. Huffman, Bill Ketron, do you guys have any data about how many children have actually in Tennessee or even Middle Tennessee received this type shot?
Yeah, not specifically in Tennessee. I will say that I believe it is worldwide. We are seeing, I think it's 1 in 50,000 are born with the eye condition requiring Luxturna, and 1 out of 6,000 babies are born with muscular atrophy that would require the Zolgensma or the $2.1 million medication. Again, that's worldwide.
But you haven't broken it down for the United States or state specific? Or
I don't have that. broken down at that point. I remember,
Cigna's not worldwide, are they?
we have clients all over the place. We had one recently in Memphis where we did deliver Zolgensma to a newborn baby a couple of months ago for another client.
Other questions? Well, I'm looking for this committee to give me either a positive or a negative recommendation, because when we start charging additional $1 per person, I think, Lisa, don't you think we need to take that to the full commission?
Mayor Ketron, this is Lois Miller again. I know that there are several more of these types of drugs in development. And Paul, you did mention that you would be adding them as they became, as we knew they were effective.
Correct.
So and I'm assuming that they would also have similar expense. In other words, crazy.
That's the assumption, is that the amount of resource and research and R&D in these drugs is so high that they are going to be in that $1 million range, if not more.
And then with the true up, I assume that's going to happen annually as well?
Correct. I don't have a date when that settlement will occur. Obviously, it's on a calendar year basis, so sometime in the first quarter, I would imagine that we would assess the expenses and the revenue that came in, and then return it appropriately.
Okay. But based on all of that, with the fact that these things are becoming so predominant and as well advertised as they are, it would be my opinion then that it would be a good move for the county.
Is that a statement or a motion?
Well, you'll make the motion, I'll second it.
Okay, I make a motion to approve the addition of this program to the county's benefit plan.
I have a motion.
The Embark program.
Okay. And a second to send as a positive recommendation to the commission.
I'll second that. This is Mary.
Mary, okay.
Okay. Now, discussion. Any discussion, questions? All right, hearing none. Mr. Bruce, please call the roll.
Okay, so this is to approve the addition of the Embark program to our medical coverage plan, correct?
That's correct.
Okay. Preble Acton?
No.
Rhonda Allen?
Yes.
I'm sorry?
Yes.
It was a yes.
Andrea Anthony?
Yes.
Doug Bodery?
Yes.
Could you repeat that?
Yes.
Amber Brown?
Yes.
Shay Crowell?
Yes.
Holly Deering?
Yes.
Mary Hickerson?
Yes.
Lois Miller?
Yes.
Jeff Phillips?
Yes.
Eric Tutubeni?
Yes.
Okay, we have 10 yes, and Mayor Ketron, your vote is not needed for the tie, and we have 3 absent.
All right, motion passes. We'll send it on with a positive recommendation to the commission. All right, thank you, Mr. Huffman. Next, we have bid results on the life, AD&D, long-term disability, short-term disability. Jay Brown, and Jake Davis with Mercer. They have been working since purchasing opened the bids, and we had to take everything under advisement. I think that's one of the largest bids we've had since I've been here, as far as the number of companies who actually bid on it. So you guys had a lot of work to do trying to sort through all the bids on each one of these because everybody had something different. So we appreciate the time that you put into it. Now I'll turn it over to you and let you give us the results and your recommendation.
All right, I'm going to kick us off, and Jake may come in a little bit. Let me see if I can share my screen for us. All right, can everybody see that?
Yes, sir.
All right, that's going to be the hardest part. All right, so as Mayor Ketron said, we did have a lot of proposals. We met with Mr. Elam and Griffey earlier, I guess middle of last week, to go through our findings. And as we went through the multiple vendors that did propose on the life and disability for Rutherford County, we did narrow it down to these four. So there's going to be a couple different pages to review, but essentially we did have several proposals, and most of them were either at 0 increase to the county or slightly higher, depending on what line of coverage that we reviewed. But just as kind of a reminder, a refresher, we'll kind of go through. Today, we'll look at the basic life, AD&D, and then the short-term disability, and then we'll look at the long-term disability, and then at the end, we have it all rolled up into one proposal. Also in this, we did look at it today. You have for your basic life and AD&D, it's currently with Cigna. Your disability, the short and long-term disability, is currently, reverse that. The life and disabilities with Standard and the disabilities with Cigna. And we did have everybody quote separately so that we could look at both options. So first we looked at the life AD&D, looked at all the benefits. So we did put some benefit detail at the top. Ms. Griffey did review all this with Jake this week just to make sure we didn't miss anything. So everything is on an apples to apples basis. Everything is for a 3-year rate period with the opportunity to extend to 1-year contracts if we choose to do that. But the rates are locked in for 3 years from everybody. And on the life and disability, when we look at the total at the bottom, Standard current is total cost here. And then we look at the renewal for Standard is no increase. So essentially they were saying we'll offer the same life and disability just as it is today at no increase. Cigna, who has the disability, came in slightly lower. But Metlife, which is who you have for your critical illness and cancer, your voluntary benefits, we put that in place last year. They came in with a price for the life and disability that's essentially $112,000, almost $113,000 lower than what you're paying today. And a lot of this cost, if we look at it, is employer paid. So there's some employer paid monies and then some employee paid monies. So just kind of keep that in mind just for a second. So at this point, if we were to look at just the life and disability on its own, Metlife would be the winner for that. Duplicating plan, 3-year rates, $113,000 in savings. If we look at the short-term disability, now we did pair the short-term and the long-term together as far as a package, but on this one, as we said, currently, you can see the current Cigna proposal here. They ended up coming in at no increase. Standard did come down on the disability. So when we reviewed that, they did come in on the short-term disability, which this is mostly employee paid, or I think it's all employee paid. So this is a $21,000 savings to the employees. Metlife came in there, not as strong as Standard. So around a $7,700 savings. So mostly employee money on this one. Life, mostly employer money. We'll tie it all together here in just a second. And then for the long term, same column. So you can see Cigna, Standard met. Cigna, Standard met here. Standard did come in lower here. So $119,000 cheaper Metlife, $37,000 cheaper. And the long-term disability is employer paid. So we have mostly employee paid on the short term, mostly employer paid on the long term, potential savings of over $100,000 here if we move to standard. So when we met with Mr. Elam, Ms. Griffey last week, went through all the proposals, kind of landed on these to present today. These are names we all heard of. We have Cigna and Standard today. We have Met today on the voluntary benefits. So opportunities there to keep people that, from what we've heard from them, and they may speak up here in a few minutes, but all three have offered great service, rather easy to work with, obviously reputable companies. So that was a positive. And then what we ended up doing here to kind of roll it all together to make it a little easier to see, since there's several spreadsheets. This one is one. So today, basic life, voluntary life, short and long-term disability, total premium today is about $2.77 million. If we were to move to Cigna for everything, we were just kind of looking at that, it would be about the same price. If we moved to standard for about everything, we would save $140,000. That was something we were initially considering. Metlife, if we moved to everything there, they're about $158,000 savings. But the most beneficial to the county and to the employees of the county really was when we came down here and said, all right, what if we moved to Metlife for the life and disability, or for the life and AD&D, and what if we moved to standard for the short and long-term disability? This was kind of the best of both worlds, and that total package ends up saving the county and the county employees a little over $250,000, which over the course of 3 years is $750,000. And unlike, say, the medical or dental, some of the other things, the employees are somewhat neutral. There's not a doctor that you have to choose or a network. So for them, the life and disability, whether it's with Cigna, Standard, or Met's, somewhat irrelevant. We'll make it real easy during open enrollment for them to get all the guarantee issues and the evidence of insurabilities when they move over. But when we discussed it earlier, based on what we've seen in some of the other meetings, the potential economic impact of COVID as we go into the rest of the year, it's probably going to be pretty difficult to pass up a $250,000 savings on something where there's definitely going to be some work on Mr. Elam's team to enroll the product with everything else going on. They'll probably mention, but they're totally happy to do that based on the savings that we're seeing. So I'll stop there and see if anybody has questions.
I think that's a great report. It proves how hungry some companies are that are willing to cut their prices. I think both companies are good companies, but if we're able to save $250,000 per year for over a 3-year period, I'd be willing to go to the commission with Mr. Elam to hire him some additional help temporarily to get the enrollment done, because I think we could pay for it in the savings just in the first year. I know it's going to be a struggle for him to do that with his small staff, but you know, we can't pass up $250,000 a year. Comments?
Mr. Chairman, this is Mary.
Yes, Mary.
A couple of things. I'm thinking, Jay, if you don't mind, can you scoot back up to, I'm thinking it's the short-term disability screen. There was a little difference. Yes, right there under standard, under the pre-existent, right up above participation requirement is at 20%. But what is that 312 or none with a 60-day? That's different from the other columns there. Can you kind of explain that before I go into anything else?
No, it's a good question. And essentially, pre-existing the 312 means, for example, short-term disability, typically that, one of the higher items there would be maternity benefits. So what they say there is so the plan would be effective in January 1. They have the ability, if there's a claim, so if there was a claim submitted, say in March, they have the ability to go back 3 months from the effective date to see if there was a pre-existing condition, and then not pay that claim for the first 12 months of that policy. So essentially, if somebody came onto the plan for the first time in January and they were pregnant and they had their baby in March, that would be covered under this year. However, if they were already on the plan before under Cigna and were just moving over to standard or Met, then that would be waived. It would just be for somebody new coming onto the plan.
Okay.
That's what 312 means.
Okay, all right, thank you, that helps on that. And then just kind of another statement in general, based on information that I have from my employees. I have had several of my employees come in that are not happy with the way their, the volunteer policies that Metlife has for us. I've had several try to do claims and are not pleased with Metlife. And so I have a feeling come October, which is when I told them they had to wait to, they would be dropping those volunteer policies. I don't handle them. I let them deal with them, but I know I have several that are not happy with Metlife on the volunteer items that we offer them. And that's just kind of throwing it out there. I totally understand the savings and we'd be crazy not to, but I just wonder, have we had dealings with the customer service on what we're asking them to cover for us?
Wouldn't this be, Mary, wouldn't this be going to standard instead of Metlife on the short term?
Now, what I'm talking about is the Metlife is we would be moving to them for their life insurance, for the life insurance.
Right.
And I have employees that have problems. They have the cancer and I forget what the
Critical illness.
And I've had some try to claim on both of them. And at one time, the same thing is covered, and at the next time, it's not the exact same thing from the doctor. So I'm just wondering, are we going to run into that problem with Metlife on the basic life insurance policy or the accident and disability? I mean, it's kind of cut and dry on that. The unfortunate thing is to make a life claim, but I'm just getting a lot of feedback because they're not wanting to give up the money that my folks have paid in for the products that they have.
Comments?
Right. I would agree, Mayor. I mean, that's some of the things we did talk about. And I think, as Mayor Ketron said, the life insurance would be going to Met, which is even what you said, a little more cut and dry. The standard, which I believe Ms. Griffey would say, we've had some pretty good experience with them. I mean, the short-term and long-term, short-term specifically is where we have a lot of questions, as you've kind of stated. That would be with standard. And we've had a good experience with them. Now, I mean, up at the top, we do have an all-standard proposal that's $140,000 savings, but that still leaves, that's $100,000 difference between the mix and match of including Met. So we kind of walk through, is $100,000 worth the difference in potential service? But I believe the insurance department would say they've had a pretty good experience with Met, but I believe there was a little bit of concern there as well.
Any other
Jay,
questions?
this is Lois Miller. I have a question as well. What would be the impact when we move the disabilities over to a new carrier? What would be the impact on the employees who are already in a current claim status?
That's a good question. I'm going to move back up here. So, Jake, I don't know if you're on. Jake was having some technical difficulties, so I got thrown in here last minute. I don't know if he's back.
Yeah, I mean, can you hear me?
Yeah, I can hear you.
Yeah. So the impact would be, if it's a current claim under the current care, that would be taken care of. If it's a new claim, come the new carrier time, it would be taken care of under the new carrier. And
okay, so if they're in current claim status with the existing carrier, then they stay with the existing carrier through their claim?
Yes.
Even if it's long-term?
Correct.
And there was built in, which is part of the experience we shared with the
But you're right, Lois. That's similar to medical. That's why they have the reserves, and it's just like that. So they would stay on the plan, like you said, with long-term disability being the main one. And there are a handful of long-term disability claims out there, but they would stay on the existing carrier.
Okay, thank you.
Other questions? Comments? Is there a motion?
I have one question before I'll make the motion. Would this have, swapping from Cigna on the short-term disability and long-term disability, would that have any effect on our current medical pricing that we have?
Good question, and no, they are separate. Or we work with Paul to make sure there's no changes on the medical, dental, or vision if we do decide to do that.
Okay, I'll go ahead and make the motion, and y'all help me out because I don't have the chart in front of me.
Oh,
We'll go with the Metlife on the life and accident disability, and standard on the short-term and long-term disability, with the approximate cost savings of over $253,000.
Everybody understand the motion? It's Metlife, standard, and standard.
This is Lois, I'll second.
Got a second from Lois. Any questions?
Okay, this is Mary again. I got another question. When we swap on this life, are we going to be able to have our guys, if they don't currently have additional on themselves, be able to pick up additional?
Jake, are you on? Can you hear?
Can you repeat your question?
Will they get guarantee issue on the life insurance if they want to get more or add as a new participant with the carrier chain?
Yes. They will be able.
Better check that.
Will get up to the guaranteed issue, no evidence of disability.
Okay, so it'll be an even swap over if they already have the additional for what they've got, and then anybody that wanted to add new could do it during this enrollment or this new swap over.
Up to the guarantee issue amount. Yeah.
Right, yeah, up to, okay, thank you.
Up to the guaranteed issue, correct.
Okay, we got a motion and a second. Any further discussion? Hearing or seeing none, Mr. Priest, call the roll.
Rebel Acton,
Yes.
Rhonda Allen,
Yes.
Andrea Anthony,
Yes.
Doug Bodery,
Yes.
Amber Brown,
Yes.
Shay Crowell,
Yes.
Holly Deering,
Yes.
Mary Hickerson,
Yes.
Lois Miller,
Yes.
Jeff Phillips,
Yes.
Eric Titobeni,
Yes.
We have 11 yes, Mayor Ketchum. We do not need your vote.
Have 11 yes. Motion carries. Any other business to come before us today? Seeing none. Is there a motion to adjourn? I'll adjourn us anyway, but thank you all.